It's my pleasure to introduce Dr. Beth DeGrush, who is the Program Director in Neuropsychiatry, who will introduce today's speaker.
All right. Hello, everyone, present and in TV land. It is my pleasure to introduce Dr. Sorrentino here. I'll give you a brief overview. Dr. Sorrentino is currently one of our chief residents, a fourth-year psychiatry resident in the adult psychiatry residency program. She completed medical school at the University of New England, or what we fondly call Unicom, in Biddeford, Maine. Prior to that, she completed her post-baccalaureate pre-med at the Harvard Extension School and a master's degree in child development from Tufts University and a bachelor's degree in psychology from Brandeis University. You can kind of see some of her development throughout her academic career. Currently, she, as I said, is one of our chief residents in the psychiatric assessment. But per her own statement, by far her greatest achievement during residency is the birth of her and her husband's son, Asher, in October 2021, which I think you will all see relates very closely to this presentation. I'll just add very briefly that Dr. Sorrentino today chooses to discuss a topic that at times can be thorny and challenging, and sometimes we just avoid talking about it altogether because of the difficult issues that it arises. And I will say also, regardless of whether you yourself in the audience are a parent, I think the implications drawn from this conversation apply to all human beings who sometimes feel they are needed in all places all at once. So I look forward to hearing Dr. Sorrentino's perspectives today, and thank you very much.
Thank you, Dr. DeGrush. Hi, everyone. I'm going to try to project my voice because I'm by nature very soft-spoken. So just let me know if you need me to yell. Okay. Get started here. Okay. So as Dr. DeGrush indicated, I'll be talking today about medicine, motherhood, and maternity leave, and be interjecting kind of throughout some anecdotes from my own experience taking maternity leave in the 2021-2022 academic year. Okay. I don't have any actual or potential conflicts of interest in relation to today's talk. Okay, so for today, just to give a sense of where we're headed, I'd like to start by describing the experiences of becoming a mother from the therapist perspective, something as in our psychiatry training, we are all trained in psychotherapy, including the effect of COVID-19 pandemic and the use of telehealth, which was a unique experience during my own maternity leave. Then I'd like to transition into describing the experience of residents who take maternity leave during training and the perceived impact on resident performance. And lastly, I'd like to conclude with proposing how residency programs can best support residents during the pregnancy and postpartum periods. Now, I wanted to preface this talk by saying that and acknowledging that I think UMass does a better job than a lot of other institutions, and that I personally felt supported throughout my own maternity leave by the department and returned to work. But as Dr. DeGrush had alluded to, I want to acknowledge that some may have their own views about this topic from decades ago. Some who are not mothers or parents themselves might not have any idea about what to expect before or after maternity leave. And women have shared with me personally stories of their own kind of microaggressions from faculty, from colleagues. And so I thought it was important that we have these discussions today. So, despite therapists on pregnancy being a common occurrence with impacts for patients and for therapists, there are a few qualitative investigations into their lived experiences. And there was one aptly titled 2019 meta-synthesis that I came upon called An Unavoidable Bump, which reviewed 13 qualitative studies exploring the experiences of pregnant and newly postpartum psychotherapists from either qualitative interviews or focus groups. And as the authors write, pregnancy is a time of change for therapists who traditionally are used to having relationships with patients be very unidirectional, that's focused on the patient's needs and the patient's issues. And pregnancy very much brings the therapist's personal life into the professional realm and signals a shift in this dynamic. So in their meta synthesis, there were kind of 4 key concepts that emerged from these qualitative interviews and these focus groups, and each of which I'll go into here. And those included the concept of identity changes, that of pregnancy necessitating disclosure, therapeutic challenges that arose, and lastly, the concept of guilt. So first, I'd like to start with the concept of identity changes. And you'll see kind of at the top row here are the 13 studies that were included in the metasynthesis. And then within each concept, there's checked off which of those spoke to each concept. So you can see here, with the concept of identity changes, a highly prevalent theme described by therapists was this emerging new identity of as self as mother. And through interviews conducted with therapists, this mother identity was frequently perceived as being in conflict with therapist professional identity. And this conflict was most pronounced in trainees whose identities as professionals are very much still in their nascent stages. And it led to feelings of role loss, role ambiguity. A lot of the therapists spoke excitedly about pregnancy, but also apprehension that motherhood would alter their self-concept. For some, prospective motherhood represented this big identity that had the potential to eclipse identities, other identities, their professional identities, as the author noted. And they worried that they might be unable to maintain both professional and mother identities concurrently, depicting the two as sort of competing drives. Pregnancy also led to a revision in therapists' perceptions of their clinical role. Many identified that the maternal and protective feelings that some had towards their patients were kind of replaced or entirely redirected towards their unborn child. On the flip side, a few therapists indicated that pregnancy actually increased maternal transference. Pregnancy and motherhood were considered to increase identification with and appreciation for clients who were parents themselves. And I think this goes both ways, with some considering that their new identity as parents afforded them a kind of street cred with patients. And I know I felt that myself. Several therapists reported increased difficulty encountering child abuse in their work and found such themes very triggering and often tended to increase the likelihood to refer such patients onward. Now, transitioning to the next key concept that emerged from the interviews with these therapists was the idea of pregnancy necessitating disclosure. And within this concept, 2 sub-themes emerged, that of telling and that of supervisory relationships. So within this concept of disclosure, and you can see the 10 studies checked off here that discuss the issue of pregnancy disclosure. There was one striking feature, and that of prima paris therapists relating the tendency to defer pregnancy disclosure until the patient brought it up themselves. And that could reflect the maintenance of the kind of traditional psychoanalytic blank screen idea where pregnancy necessitated a clear violation of the therapist's anonymity. But a lot of therapists spoke of regretting deferring disclosure until later and attributed it to real lack of kind of clinical guidance and supervision around disclosure and how those conversations should be had with patients. The majority of therapists reported disclosing pregnancies in the 2nd and 3rd trimesters. And although a lot of therapists acknowledged that kind of social etiquette dictated that maybe the patient didn't want to broach the subject themselves, a lot of them considered it odd. Like there was one therapist who noted, I had to tell her at 7 months, I couldn't believe the patient hadn't said anything. I was bigger than a house. It was so obvious. Conversely, prompt disclosures were reported more by multi-paris and more experienced therapists and those initiating therapy with new clients. And this sharing news of pregnancy with patients was described frequently as emotionally complex for therapists. It produced an array of effective responses. A lot of the therapists said it gave them a sense of relief, like withholding felt secretive, it felt unnatural, it felt like a betrayal, and was very difficult and very anxiety provoking. And I can attest to that as well, because of fears that you were going to somehow incite patients' anger or somehow cause a therapeutic rupture. I wanted to kind of pause here while we're talking about disclosure and telling. Now, when I was pregnant, it was early 2021, and the COVID-19 pandemic was in full swing, and everyone was still on telemedicine, and everyone was still quarantining at home. I think that the pandemic really affected all of the concepts that we're talking about here, but particularly I thought it was most pronounced for disclosure. There was no need to attempt to conceal my pregnancy because patients had only known me from like the head up. And so as a result, I can absolutely identify with this notion of sharing, of actually telling my patients as producing this sense of relief. And many of them were very surprised because they had no idea. And withholding it indeed had felt secretive. So I just would like to go back now to returning to the concept we were talking about of telling and supervisory relationships. Now, across a lot of the studies, there was this theme that kept coming up about the dearth of advice from supervisors about pregnancies, even when supervisors were very highly skilled and highly regarded in terms of managing other issues. Supervision was really perceived as inadequate in terms of like managing the impact of pregnancy on therapy. And on the flip side, therapists reported discomfort discussing their pregnancies. Often if they were with male supervisors who didn't have children themselves. And a lot of therapists voiced a kind of a general preference for female supervisors who had experience of providing therapy while pregnant or liaison with formerly pregnant colleagues. So transitioning to the next key concept that emerged from the interview with therapists was this therapeutic challenges. Now, a lot of the therapists tried to explore clients' affect around pregnancy and expectancy, and those who were able to describe pregnancy exploration as very powerful, I think it provided a lot of material for discussion in therapy, including patients' own experiences of pregnancy, their own experiences of being mothered. I think increased candor was reported to facilitate the shift where therapists felt more real to patients. They were seen as more of human rather than just a therapist. But conversely, sometimes disclosure could also lead to inhibition of patients' affect or inability to stimulate exploration. And it led to early termination of therapy. There are other therapeutic challenges that came up in these studies, that of uninvited touching of the therapist's stomach, receiving baby gifts, neither of which, fortunately, I had to sort of contend with because of telehealth at that time. And finally, I want to talk about this concept that came up of guilt. Therapists in the studies shown here described experiencing considerable and unrelenting guilt related to pregnancy. It was, for some, viewed as an abandonment of clients, and it was especially pronounced in child therapists. These studies include, I should have prefaced, both adult and child therapists. Interestingly, for some, they describe pregnancy as this like physical manifestation of the differences between their lives and their patients' lives. It was this idea of like, I have everything and they have nothing, and it only served to further heighten their guilt, particularly for patients struggling themselves with infertility issues. One therapist commented, "The session I told them I was pregnant, I didn't even want to charge them. I felt so bad." As mentioned, the feelings of guilt were especially pronounced for child therapists, and some felt like they had to rewrite this sort of fantasy they had where they were the child's closest ally, because now they were abandoning this child sort of out into the world where nobody cared. And pregnant therapists also described the physical symptoms of pregnancy, like nausea, the feeling the baby's movements as distracting, and dividing their attention during clinical work. And that, I think, that also contributed to feelings maybe of guilt, or even like they were inadequate during the sessions. So as the authors noted, there was kind of little professional guidance on how to navigate all of these clinical issues that come up in response to a therapist's pregnancy. And there's sort of limited supervisory sometimes or organizational support available for pregnant therapists. So I thought this really highlighted the need for kind of improved frameworks, especially around the supervisor trainee dyad, to kind of have conversations around these and have exploratory discussions with the supervisors as serving kind of as a template for the trainees' conversations with patients. So up until this point, we've been talking about the experiences of pregnancy and newly postpartum psychotherapists, but now I kind of like to transition, talk about the experiences of residents, medical residents specifically. Just going to stop to drink a sip of water. So residents, not that I need to tell anyone here this, but experiencing pregnancy during postgraduate training is becoming more common as the number of female residents increase. And medical training is long and it extends through the childbearing years. And so a lot of women, because of a desire for children and concern about decreasing fertility with age, choose to start a family during residency. And I didn't want to get into too much in terms of policy in this talk, because I think that could be an entire talk in and of itself. But and I'm certainly not an expert in this, but from my kind of research, there seems to be a lot of variability among GME programs in the US in terms of like how parental leave is offered and utilized. The ACGME historically required institutions to have parental leave policies in place, but kind of deferred to like individual institutions in setting specific guidelines. In July of this past year, in 2022, the ACGME updated its guidelines to mandate that all programs offer 6 weeks of paid parental leave to trainees. But as Dr. DeGrush kind of alluded to, there's still a lot of stigma, I think, and concern, both from resident sides and training departments. And I think it's, from what I saw in the literature, most pronounced in surgical specialties, surgical subspecialty residency programs. A lot of the literature on pregnancy during postgraduate training that I came across was from surgical residency programs and from family medicine residency programs. And interestingly, I didn't come across a lot in literature on the resident experience of childbearing in psychiatry training programs. So I thought that was particularly interesting. I know it's not maybe as physically intensive as some of the other programs, but certainly one of the most emotionally intense. So in continuing the theme of pregnancy during residency training, there was one qualitative study. This was conducted with family medicine residents in British Columbia. And it was, again, semi-structured telephone interviews with residents, so again, qualitative data. And the interviews kind of were conducted across 3 phases that we'll review here: pregnancy, maternity leave, and returning to work. And throughout each of those phases, residents were really presented with unique challenges and unique support requirements. And I just wanted to highlight some of the themes, and I apologize if it's difficult to read from there, but I'll speak to them each. Some of the themes that emerged during each of these 3 phases, and we'll start with the pregnancy phase. One theme that emerged was this perceived increased adverse symptoms because of workload. A lot of participants reported increased physical symptoms during pregnancy, like excessive fatigue, contractions, bleeding, musculoskeletal pain, and attributed it to kind of heavy workload of clinical duties that improved after they took a leave or rest. Another theme that emerged for residents was prioritizing work over well-being. Residents in the family medicine rotation, particularly during like OB-GYN surgery, very physically intensive rotations, reported a lot of external and internal pressures to prioritize work over their well-being. There was high workloads, there was frequent call, they perceived like there wasn't enough support from preceptors to sort of manage the workload. And there was also internal pressure rather, a strong motivation to kind of be keen and competitive as residents, which I think disinclined people to ask for help. But participants did note support from the residency program. This was a residency program actually in British Columbia where they get quite a bit of maternity and paternity leave. They noted that programs are offered to arrange for requested time off, provided exemption from night call, especially after 28 weeks of gestation, rearranged rotation schedules. And residents found these as very helpful in kind of reducing stress from pregnancy-related challenges and maintaining their clinical function. So the next phase that the interviews focused on was the phase of the postpartum maternity leave itself. And most participants actually took 8 to 12 months of maternity leave, which is very different than we have here in the US. But the themes are the same, I think. A lot of the residents spoke of postpartum depression, anxiety, especially immediately before returning to work. Again, this theme of identity crisis came up that we saw in the interviews with psychotherapists. One resident reported feeling helpless by the sudden transition from being a trained provider of like evidence-based medicine to being this very inexperienced new parent, and referred to it as having an identity crisis. And then lastly, the return to work. So though the residents described their programs as supportive kind of throughout pregnancy, throughout maternity leave, a decrease in support upon return to work was a recurring theme. A lot of the participants who had already returned to work, and most of those on maternity leave had reported challenges and anxiety when coming back to work, like impaired memory because of sleep deprivation, which I can definitely identify with, fatigue from their duties at home, duties at work, limited time to study after work, increased workload with trying to squeeze in breast pumping. A lot of residents talked about feeling rusty, feeling inferior to other colleagues because of the limited time availability and fatigue and memory impairments. Breastfeeding, that was reported as challenging. A lot of residents felt like they didn't have private rooms, fridges that are available in some rotations. We here at UMass at the medical school do have mother's rooms available. Pumping breast milk added time and kind of another task to residents' workload. About half of the participants who were breastfeeding their babies at the time of returning to work actually gave up breastfeeding because earlier than they had planned because of sort of this increased burden of breast pumping at work. And then this idea of shared burden of residency with family. A lot of the residents who were interviewed reported sharing the burden of residency with their own families. They reported that even though they had hoped to spend more time with their babies and their partners, they felt the pressure to prioritize work over family because of the unpredictable and lengthy hours of work. A lot of them were too exhausted to spend time with their families when they did get home, or felt a need to kind of compromise family time to study. And that, I think, added to the sense of guilt about kind of neglecting families. Another issue that came up from these interviews with residents was the limited availability of childcare, especially for residents at kind of more urban sites. And the wait times for daycares at the spots were as long as like 3 years. So working residents were really trying to scramble and rely on partners, extended families to take care of their children. And it made it hard because their work hours were often unpredictable. We here at UMass do have on-site daycare, the Bright Horizons, which is great. Okay, so continuing with this kind of theme of residents returning to work and supporting residents beyond like the immediate birth of a child, I wanted to go into one exploratory qualitative study I came across. This was in 2016 of male and female family medicine residents, this time in the US. It was a Midwest program that they used focus groups to kind of understand their perceptions about the positive and negative characteristics of their role as physicians and as parents. And so the analysis that the authors did resulted in this kind of model that emerged of work-family conflict, where both family and residency produce demands that compete for residents' time. And those competing demands often lead to difficult choices that residents have to make, which can generate positive outcomes and sometimes generate negative outcomes. The residents' discussions about their families, you can see at the top here, primarily focused on support provided by spouses and extended family members. A lot of residents kind of have made this assertion that they wouldn't be able to do it by themselves. That was echoed by many. Others talked about how families were affected by their residency responsibilities. They commented on their inability to parent as actively as they liked. Participants were largely responsive in their discussions of the faculty, staff, and fellow residents they encountered during residency. There were positive elements that included there were support for breastfeeding, there were family-friendly social activities, some negative elements including requiring residents to flip-flop days and nights during their schedule. Participants described, and I included this quote because I think it really resonated with me personally. Participants described a lot of instances where sort of demands of parenting and residency conflicted. It required them to make choices about how they spend their time. One participant explained, I try to be a good doctor, maybe not the best, and a good mom, probably not the best, and a good wife, probably not the best. It's this balancing act. Indeed, the personal and professional needs of resident parents often collide with like hospital workforce needs, expectations from co-residents, and the requirements of like the ACGME and the American Board of Medical Specialties. So some positive outcomes of parenting that was discussed in these focus groups with residents, including we were really forced to draw a line between work and home. Additional positive outcomes were increased empathy with patients. Some of the negative outcomes that residents described was feeling, again, this theme of guilt came up. Guilt when asking for time off, experiencing a nagging feeling that time spent with family means like other work-related responsibilities like working on your notes would need to be done later. Let's see, the outcomes of attending to work versus family were generally perceived as negative and included, as we described, feelings of guilt, feelings of not being able to offer more support to your spouse, and desiring more time with family. And so I just wanted to pause here and turn towards, we've been talking a little bit about concerns, both from the resident side and training department side of this concern that maybe parental leave could affect negatively resident performance. But I was curious, was that actually based on objective data? And so I found there was in JAMA Ophthalmology a retrospective cross-sectional analysis in 2022 that examined the performance metrics across 10 ophthalmology programs in the US. And this was including Johns Hopkins, Duke, Harvard, for residents who used parental leave during residency versus those that did not use parental leave. And so there were 44 of the 44 residents, 16% who used parental leave. There were, this is looking at the performance metrics here. There were no differences you can see in what's called the OCAP, the Ophthalmic Knowledge Assessment Program. No differences between the two groups, those who took parental leave and those who did not. There was no differences found in research activity during residency. And continuing on, you can see here, there's ACGME milestones listed here: patient care, medical knowledge, professionalism, practice-based learning, interpersonal skills, average ACGME milestone scores, and also surgical volumes at the bottom. There was no difference between those who took parental leave and those who didn't. Now, this included both male and female residents, and the male residents tended to take a much shorter leave than females. Some took as short as a week compared to females, and so they stratified the results by sex to examine kind of female resident performance specifically compared to all residents who did not take parental leave. And that table was kind of too onerous to include here, so but again, they compared OCAP performance, ACGME milestones, research activity, found no differences between the two groups. So I'd like to kind of transition here to talking about the transition to work after maternity leave that we described previously was found to be kind of one of the biggest challenges for childbearing residents from the focus group studies I alluded to earlier with the group of family medicine residents. And so I think there's sort of further research warranted to kind of explore strategies to fully support this population for successful transitions back to residency after pregnancy. I did want to highlight in terms of exploring what are some of the ways we can help support residents, not only with returning to work, but with the pregnancy and postpartum periods in general. These are some of the resident recommendations from the earlier qualitative study of family medicine residents we spoke of for ways to increase support and ways to increase parent-friendly culture. And so I won't read all of these, but just kind of some of the highlights, including exploring the possibility of on-site daycare, which, as we noted, UMass does offer here at Bright Horizons. One that I did want to highlight, because I think it was one that I felt strongly about, was making available faculty who are willing to kind of provide mentorship on balancing responsibilities of residency and motherhood. And continuing with that theme, there was an opinion piece written not long ago in 2022 in JAMA Surgery, written by some of the attendings in their general surgery and gastrointestinal surgery department at the Brigham, who were putting together a formal mentorship program, advocating for the creation of a formal mentorship program, sort of which is outlined here, and I'll go through. And the goals of this mentorship program, including, beyond like providing practical advice and kind of role modeling positive behaviors, but serving as a reporting system for mistreatment, acting as an advocate to faculty and leadership if needed, and also included virtual mentorship for trainees if needed. And the figure here kind of outlines what such a mentorship program could look like, including it's very detailed in terms of like how to structure meetings with trainees, providing a welcome workbook of practical guidelines that kind of outlines leave options, provides example of how other residents have structured their own parental leave that's in compliance with ACGME policies, local lactation, local childcare resources. And I think, and as the authors write too, these kind of mentorship programs, I think, provide legitimacy and structured support for the needs of these residents that I think could ultimately improve career satisfaction and kind of successful transition into a trainee's new role. In this case, as surgeon and parent, but in our case, in my case, psychiatrist and parent. And so I wanted to end on that note. These are references from the qualitative studies that I gathered as part of my presentation, and also the data on the resident performance from JAMA Ophthalmology and the opinion piece in JAMA Surgery we spoke of. Thank you.
Anybody have questions in the room? I have a question then. I'm just wondering.
Yeah.
This, I guess, would apply to medical students and residents. What do the accrediting bodies say? I mean, if you take maternity leave or paternity leave, does it delay your graduation, or have there been ways to figure out that it doesn't?
Yeah, that's a great question. I think, and I don't know if Dr. Gerslett has been able to speak to this better than myself, but my understanding is with the recent ACGME guidelines from this past July, that all programs provide 6 weeks of paid maternity and paternity leave. I think it's still up to the discretion of individual programs in terms of, have residents met their requirements and the competencies such that they are able to still graduate on time, or do they need to extend their training? I think that decision is still deferred to individual programs. Oh, and Dr. Padisha is here too.
Yeah, this has been an interesting discussion for a couple of years. And so the ABPN also has different recommendations of allowing at least once in your training that you have a leave without using your personal time or your sick time. But then they don't give further recommendations of how do you count the requirements or how do you do both at the same time. So it's ultimately is up to the programs to decide if a resident, and in our case, the clinical competency committee is the committee that meets and makes the decision. But for programs like surgery, where you need to have a certain amount of hours in the OR or a certain number of procedures, that complicates things even more because it's impossible to do both at the same time.
Mm-hmm. Absolutely.
Other questions? Yep. You can keep this one back here.
Thanks, Erica. You did a really great job, by the way.
Thank you.
You're welcome.
I think my question is about whether or not you came across studies about pregnancy complications and the sort of relative risk of pregnancy complications in residents versus the general population when like controlled for, other risk factors. The reason that I bring this up is that I think there's just a lot of like anecdotal stories about residents that that you hear having to, take leave for preterm contractions because they weren't sleeping enough or because they were dehydrated or, people having to go out on leave early. And so I was just curious if you came across any data that sort of represented those anecdotes.
Yeah, that's a great question, Maggie. And I could have, I feel like gone a lot of different ways with this talk, and could have gone that route and could have included additional data of their actual differences between residents and, as you said, kind of general population in terms of pregnancy complications, preterm labor contractions. A lot of what I came across was sort of from the qualitative interviews I looked at, residents who did report that they had kind of increased physical symptoms and complications, as you suggested, but that it was hard to tease apart and necessarily even though there's a correlation, like prove their causation in terms of that it was because they're in these very physically demanding residency programs versus would this have been a complication had they not been in these roles. So I think I came across a lot of that data. It seemed like it was hard to necessarily attribute it to their role as residents.
So Dr. Hicks in Zoom land has a question and a comment. So Can you unmute yourself, Dr. Hicks? You're going to be unmuted from here. All right, there you go.
Okay. Comment, it's really great presentation. Thank you. One thought about the fine-tuning of a residency program. It seems that if this residency program did lay out a kind of plan like this, it could be an example of good practice for residency programs, which could be a really interesting paper for residents and faculty to do together. But the other question I have is, in terms of encouraging and normalizing parental leave, do you have thoughts about whether maternity leave could be more normalized and acceptable rather than exceptional? By also encouraging paternity leave. That is to say, this isn't really only a female problem, although it has unique aspects. Any thoughts on that?
Well, absolutely, Dr. Hicks. And I didn't mean to exclude too the non-birthing parent from this talk. There was a lot of, I feel like I may have been trying to do too much, including that here, but there was a lot of research that I came across in terms of non-birthing parents. And as we saw from that, the one study of resident performance among ophthalmology residents, some of the male residents taking as short as a week time to be with their partner. So absolutely, this is not just, as you said, a maternity leave issue, but really it should include the non-birthing parent as well. I think I just, within the scope of this talk, didn't include that. But absolutely, it should be normalized. Oh, thank you, Haley. Yeah, no, oh, sure. Haley, you were just asking in terms of, did I come across any research in terms of perspective from co-residents in terms of their residents taking maternity leave, good or bad, what their experiences were. And a lot of what I came across was from the perspective of the resident themselves, how they perceive their co-residents and faculty of their own taking maternity leave. So not necessarily from the co-resident or faculty themselves, but a lot of what I read was sort of their interpretation of how they were being perceived, and good and positive and negative. Some describe very supportive experiences with co-residents, allowing them to switch call schedules, just like supportive gestures like that, but also sort of more of these kind of microaggressions of that they felt as a result of taking maternity leave. I think, and they felt guilty as well that they were putting more work on the residents, their co-residents. Whether their co-residents picked up on that, I'm not sure, but they definitely a common theme I found was this feeling of guilt, like I'm dumping on my co-residents this increased workload. So to answer your question, I didn't come across anything directly from the co-residents or faculty themselves experiences, but more the interpretation through the residents.
Just a comment, Hallie, I think that would be a great paper, and we can include the resident feelings about program directors taking I will be interested in that. But my comment was going to be a vulnerable comment, because I'm thinking about this is not just a resident issue. You're a early career, late career. If you're in the situation, you have similar feelings. And thinking about the mentorship part, it's funny, Dr. DeGroche, I'm throwing you under the bus as well, but you and I are always talk about how do we model this life balancing act. And, initially as an early career, I felt like I needed to demonstrate that this is possible and this is how you do it and how you're professional. But really, it's more about this is life and this is hard. And that's the best that we can do, is demonstrate that that's the truth and that Absolutely. It's not a unique issue for each resident. That was it.
Absolutely.
Make sure it's on.
I think
testing. Okay, yeah, it's on. So thank you very much for bringing up this topic. This is an awesome topic. And also for leaving time for communication about it.
Indeed.
One thought that I had about this, make this an issue for everyone. Why just maternity leave rather than making it like a gendered issue? What about comparing this leave for people who take medical leave for reasons aside from pregnancy?
Absolutely.
And I'm wondering if you came across anything that compared people who took extended leave for medical reasons as well, for other medical reasons.
No, that's a great comment, Sarah. Thank you. I didn't because I think my search was sort of specifically on maternity leave itself, but I can imagine that, and I'm just hypothesizing here, and that the feelings of guilt that this was something that was sort of being inflicted upon patients, inflicted upon co-residents, is not the same as when people take medical leave for other reasons other than pregnancy. I don't know if that's actually the case. I would hypothesize that it may be, but that's a great question of the sort of how it's perceived. Also, to speak to Haley's point, from like co-residents' perspective, people going on maternity leave versus taking medical leave for other reasons, and are those views different? Absolutely. Hi, Kim.
Because I took maternity leave, but before that I had medical leave.
I'm going to get you here. I'll get you on my.
Yeah.
Okay. Oh, I'm sorry. I'm sorry, Dr. Rothschild. I should not take over this. I apologize.
All right. So while we're sorting out mic access for that side of the room, I just want to respond about the data around pregnancy, birth outcomes for mother and baby. So not specific to residents, but across medicine. Providers have worse outcomes than the general public, which of course is shocking because we should have good knowledge and good access to care. But there are both more pregnancy complications or birth-related complications and poorer recovery outcomes. So across the board, poorer outcomes for both mom and baby amongst female physicians in particular. And we already know, right, that fertility is also something that is reported to be highly impacted by this career choice. So I think it is something that the profession needs to think about in terms of both the pregnancy and the recovery. And if I could say one other thing, this is something that came up very much in surveys of residents around the new union and negotiate what things to prioritize and negotiate for that. And it's coming to the point about other non-parent residents, really a lot of tension there about how hard residency is and how many things that people juggle outside of work, even if they're not parents, and how, some things can be spoken about, some things prioritized. In some ways, like a medical leave doesn't feel like it's a decision, whereas parenting might be seen as a decision or breastfeeding might be seen as a decision, but also in general, as a society, we tend to promote parenthood. And so that might be considered a reason to give leave, whereas other things might not. And just this tension as residents advocating for other residents about how to span that uncomfortableness. I think it's not just about medicine. I think this is in all workplaces that people have this uncomfortableness about how one person's life is affecting others. How to be fair and equitable.
I think that Elaine kind of summarized really well kind of one of the points I was going to make about maternity leave versus medical leave being in or out of our control, and maybe the response that gets from other people. And also the guilt that comes with a medical leave that's out of our control versus a maternity leave where you're actively making the decision. And I think it has to do a lot with kind of, as a parent, or prospective parent, your perception of what other people will kind of think and feel about the decision you're making.
Absolutely. Absolutely. Thank you, Kim.
Comment from Dr. Kogan, similar to what has been said. She put a study in the chat where residents do have more pregnancy complications than others of similar demographics. And this may be similar to others working manual jobs and or nights, but risk is probably still elevated.
Thank you, Dr. Kogan.
Hey, Erica. That was a wonderful presentation.
Thank you.
I'm just curious. So I know that we kind of went over what the different systems in place are thinking about doing and considering and even implementing. But I'm also just kind of curious to hear from you and any other parent in the room, what do you think in your anecdotal experience is truly needed to support parents who have children throughout this process in residency?
More hours in the day, indeed. A third hand, clone myself. Yeah. No, thank you for your question. And I invite other parents to comment. This is just sort of from my perspective. But I think one of the biggest things, besides the practical needs of childcare, for some spaces for lactation, I think beyond those pragmatic needs, something that I think has been discussed here is just kind of a general awareness of the difficulty in sort of these dual roles as physician and parent, as resident and parent, kind of an awareness of that. And I think that's the biggest factor, because I think that there's from that increased awareness can kind of lessen some of these feelings that you mentioned, Kim, of guilt in particular. And so I would say beyond the kind of practical needs, sort of an awareness of this is kind of a reality of what our days look like when we go home from the hospital, and just having these kinds of conversations and bringing up these uncomfortable talks of about how difficult it is. Just, I think, increasing people's awareness is one of the biggest steps, because I know for myself personally, before becoming a parent, I had no concept of what it was like. My life was residency. And so I think that's a big first step.
Hold on, nobody can hear you. We can get another 80 people online.
Sorry, I was just saying, I think something I noticed on the list of factors that would be beneficial that UMass does, and that I think is really important, is allowing residents to break up their time off into increments. I think that is huge. Just allowing flexibility in how you schedule your time off, and also having 3 personal days for kind of last minute issues. And then I think kind of getting more to the impact on coworkers. I think, I don't know how this would play out, but I think having a system in place that can minimize that impact, and whether that means relying more on like moonlighters or, other staff members who are going to get compensated, as opposed to, relying on your co-residents to take up extra shifts or things like that. I think that would help a lot on both sides, ease guilt and also help lessen the impact.
Thank you for bringing attention to this topic, Erica. I had a mentor who once said that medicine is a very jealous lover, and I'm guessing that when you're a parent, that becomes even more apparent. But a question I had, you had mentioned, and we briefly talked about how residents can be more supportive, and I was wondering if you can, like co-residents and colleagues in general, I was wondering if you can talk more about that, if you've seen things in studies or, anecdotal experience.
Just I think one thing that I found particularly helpful, just kind of like anecdotally from my own experience, was just trying to get an appreciation of what like we talked about earlier, kind of what does your life look like when you leave the hospital? Because I think it makes people feel like less so that you're trying to shirk your responsibilities, or just to get kind of be curious and ask questions, and it's no one will be offended. I certainly would have been. I want to talk about it. Like, what is your experience like? What does it look like when you go home? On the weekends, we're not just sitting at home anymore, like studying. What does it look like? And ask how, if you feel like a co-resident is having a particularly difficult time with this balance, asking questions about what can I do to help? And just be curious. I know it can be tough for like non-birthing parents and like non-birthing residents, but I think being curious and about it is a good place to start. So I know that's what I tried to do with co-residents before I ever got pregnant. So I don't know if others have idea of what might be helpful.
Could you pass the mic back to Sarah? Did you have a question also? I'm sorry. Did you have a?
This is on a topic. No, finish.
All right.
So I agree, Erica. I think that's a really good point. I also think that it's very fair to say that having a colleague who's taken maternity leave or leave for any reason can bring up a lot of concerns for co-residents and colleagues. And sometimes like just being open about it and sort of like trusting that the people who took leave will be understanding of that and empathetic, to just get it in the open and have a collegial conversation about it. That can go a really long way in forming like stronger relationships with your colleagues. So I would advocate that it goes both ways, like curiosity as well as like openness. Those things are just gold in my opinion.
Absolutely. Thank you, Sarah.
In a sort of similar vein, I know that you had mentioned that a lot of the mothers who were therapists had said they felt guilty about potentially like abandoning their patients. And I wondered what the flip side of that, if there was any literature that was examining if the patients felt abandoned and if disclosure actually reduced that and increased empathy for the therapist, or some sort of a connection where maybe they'd anticipate, like if something were to happen, I would know that they told me what's going on.
Hmm.
I'm not kind of out like in the dark. And I don't know if that would be what your thoughts were on that, or if you had found anything.
Oh, thank you, Lexi. A lot of what I read about was from the psychotherapist perspective, but I think a lot, like some of what I came across through those articles from that talked about the kind of the patient's perspective, I think it often was informed by like the patient's own experience of either being a parent themselves or being mothered. I think that had a lot to do with kind of how they responded to the therapist disclosing their pregnancy to them. For some, it was an opportunity for them to kind of be like have a role reversal where they felt more kind of concerned for the therapist. They were like acting in a maternal role for the therapist. And I experienced that a little bit with some of my patients. And then the flip side, some patients kind of terminated therapy early. I think felt like it was maybe an abandonment. She's not going to care about me anymore. I'm not a priority. So I think sometimes it had to do with like the patient's own experiences informing how they responded to the therapist disclosure. But a lot of what I read is sort of from the therapist perspective, but I imagine that there's quite a bit in terms of the patient perspective. So there was also some interesting literature that I didn't go down because I think you could go down rabbit holes with some of these topics, but the patients who learning of their therapist pregnancies, there were some fantasies that like the patient wasn't going to be sort of available anymore, that like they had these, this gets a little, I think like down a rabbit hole, but that the therapist wasn't going to be available anymore sexually, that now they were no longer sexually available. There were also, I think, responses from patients. So I didn't go too down that literature route, but I think there's a myriad responses that patients have, and they're not always verbalized.
Well, thank you very much. This is very interesting. I would make one suggestion. There's a possible very good mentor on this issue, which would be our chair, who had triplets early in her career.
Yes.
Well, listen, thank you very much.
Thank you, Dr. Rothschild. Thank you, everyone.